Relapses are unfortunately part of the natural history of the disease. I would like to add comment that relapses for some of us are not necessarily inevitable. I think it is important to remind ourselves that we made progress, that there's a lot of patients who will not be relapsing, and it's increasing proportion of these patients. But if relapses are to be expected, they are to be expected earlier in patients with so-called high-risk disease, which is by most of the evaluations based on either cytogenetics or other risk factor assessments. There is clear correlation, regardless of treatment strategy, for having this relapse coming earlier for high-risk disease than later. I would like to stress again that this is not inevitable for a given patient, but for a proportion of patients with high risk versus good risk disease, those with high risk disease will have, on average, earlier relapse. But you may have still patients with good risk disease relapsing relatively early, unexpectedly, because of other factors which we may not know, or those with high risk factors doing potentially better than expected, because those risks are very much just assumption of potential for relapse. So to just frame it maybe in some form of summary, disease tends to be relapsing very much late after the first treatment approach, so-called initial therapy, frontline therapy, when this can happen on average between 3 to 5 and now possibly even 6 to 7 years, and maybe never again. I would like to be still optimistic. And in next lines of therapy, as we call it, after second or third or more relapses, the duration of those responses may be in general shorter. Again, nothing absolute for a given patient, but statistically that's how it plays out. So we know that we can potentially be having those type of expectations or maybe observations when we start treatment. And then I personally, when I am approaching it and I speak with the patient, I'm trying to stress that we do know a lot, but our knowledge is not absolute in terms of what will happen with given patients. So I wouldn't be falling into desperation because of having high-risk disease, and be always careful with any status of the disease how things will play out. The triggers to switching therapy are to some extent established, and to some extent are variably approached by many of us. And I think if we would poll top myeloma specialists, we probably would not get a uniform answer in this regard. I will maybe discuss my philosophy and my approach in the context of what we know. So I am generally not switching therapy if patient is tolerating treatment, is in response, even if shows signs of early progression of the disease, but not necessarily meeting criteria for progression of the disease. Those criteria is established by International Myeloma Working Group, and they are really required for initiation of new treatment, for example, on clinical trial. Exceptions are made, of course, but that's a general rule which I have been applying. Why? In early relapse, when disease, for example, are either absent or 0.1 M spike increases by 0.2 or 0.3, that may be sometimes quick progression, and that period of continued treatment on prior regimen may not be too long. But I know also from own experience and from data which is in literature that sometimes the emergence of progression is essentially a long process, especially in patients with low proliferative disease, which is usually lower risk disease. So they may benefit continuously from this extended treatment. We need to be vigilant. The disease is not emerging in a different way than by observing just myeloma proteins like M-spike in the urine or serum or free light, but also check periodically imaging, because sometimes disease may silently present in the form of plasmacytoma. So it is a period of more vigilance in monitoring the patient. If the line of progression of disease is crossed, which is well established in International Myeloma Working Group criteria, for the most part, I discuss with the patient change of therapy to different treatment. There are some who might potentially, at this point, either stop treatment or continual treatment until there is emergence of organ damage, like for newly diagnosed myeloma. These were old criteria for restarting therapy. Having one of the CRAB criteria, calcium elevation, renal insufficiency, anemia, and bone disease, or other newer criteria right now. I think for many of us, for me for sure, it is at this stage when disease is relapsing not good practice and not in the best interest of patient to waiting until that point. I think that specific timing of restarting new treatment may be negotiated or moved if disease is really slowly progressing. But in general, when disease is starting to progress, I consider a new therapy.